starting with the targeted fetal neurosonography. And as everybody knows, best preferred approach. So TVS is best. It's the most preferred one. Why? Because TVS is the scan which offers us a high resolution images. So high resolution, that means better images, that means a better image to analyze, and hence a better image to diagnose issues. It gives us optimal imaging access. So when you are doing TVS scan, you know that the footprint is small, so you have better maneuverability and you get access to fetal cranial sutures and fontanelles through that small footprint. It should always and always be used if your fetus is in vertex presentation, because you have multiple advantages in TVS than TAS. So in certain situations, like if the baby is breech or you have a complex presentation, for example, in twin pregnancy, there's less space, so baby does not move, or for that matter, any technical limitation not letting you perform TVS, in such cases, you go for transabdominal scan. So if I'm doing a transabdominal scan, which probes should I select? High resolution, linear, preferably microconvex. So linear or microconvex transducers, they are encouraged. You should have a multi-band frequency like 8 to 9 hertz. Why are we focusing on the microconvex transducer? Because they are offering us high spatial resolution, the same advantage that you had with your TVS. So better to prefer this high-end transducers. Neurosonographic examination is completely based on the multiplanar approach. So in screening, we focused on the axial images. So in the dedicated targeted neurosonography, you are going to focus on sagittal and coronal planes in addition to the screening axial planes. So optimize the axial imaging as well. So all the three planes will be used while you are doing the neurosonography. What are the techniques to perform neurosonography? The first is you directly acquire the planes. How do you do it? If the baby is in cephalic position, we'll go for transvaginal scan. If baby is breech, then transfrontal or transabdominal approach. So if the head was here, then we can put our probe in the fundus. Now you can use high resolution linear or microconvex transducers for this. Otherwise, if the presentation is very complex or there is some other technical limitation like high BMI, you can use 3D volume reconstruction. This is known as indirect reconstruction, and we will be discussing this in detail in the next class. So how do you do 3D scan and how is it helpful? You have multiplanar imaging, rendering, VCI. So they will help you do the same thing which you were trying to do it manually. So first thing, in difficult cases, 3D can be used. Second thing, this is going to save a lot of time. It's time saving. But you need dedicated instrument. You need a good volume probe. Volume contrast imaging. So these are the modes of 3D imaging that will serve different purposes. So multiplanar, you can achieve rendering, you can get the 3D image of, say, a partial agenesis of corpus callosum. It's just like easier to explain to the patient or the consultant, referring consultant. You can show, you can label it properly that this is what the part is synthesized and this part is not. So rendering is used there, and then VCI. So these are basically the advanced further branching of 3D imaging. So why TVS? Why is TVS preferred technique? Because higher image resolution. You have unobstructed visualization of the sagittal and the coronal planes. So if the footprint is small and you are targeting the fontanelle, so when you put your probe in that small fontanelle, you are not going to come across any bone. So you will have a very good image and you will avoid the calvaria. So a nice high quality, high resolution image is possible through TVS. If you see in this image, we are targeting the anterior fontanelle here. So slight pressure is always given, so acquiring the sagittal plane, and then if you rotate your probe by 90 degree, you will get good coronal planes. What if the baby is in breech? Then you take the transfrontal approach. So probe is positioned on the uterine fundus, and depending on the orientation of head, you will acquire your axial, coronal, and sagittal images. Now, there is something which I have seen experienced radiologists do, that is external version. Now, what is external version? So, with one hand, they are dealing with the probe, and they are applying adequate pressure, doing the fine movements so that they get the proper plane. But what if the baby is not having a good orientation? It's constantly in oblique position. With the free hand, they also maneuver the head of the baby, or slightly they maneuver the baby. So that is a gentle version of external cephalic version that I have seen people do, and that can be attempted. When is it feasible? When you have good amount of AFI. So if you have good liker, gentle external cephalic version will help you achieve the ideal planes. So we'll also see a video where the neurosonography is being done by a very respected sir. So we'll see how he is maneuvering with the probe and how the images are being displayed on the screen. So that's a real life imaging. So you will understand how you will shift from axial to sagittal plane. Shifting sagittal and coronal is relatively easy, but axial to sagittal is a little difficult because the same thing will not happen at the same place. You will have to move your probe to the other side of the abdomen. That's very nicely displayed in that video. But when we will finish everything, in the end, we will see to summarize it in the next lecture. So this was about the CNS, the brain. So we saw the axial plane, coronal, and sagittal. So evaluation of spine is also a part of our neurosonographic examination. Again, the three plane. The ideal identification is the ideal work is to identify the conus medullaris. That is the question, the main question of the hour. Whenever you are imaging the spine, your report should always mention where the conus medullaris is located. Now, this is the position of conus medullaris. So you will start counting. Now, this arrow is pointing to me at the transition from the lumbar to sacral. So L5, 4, 3, and 2. It should be between 2 and 3. So if it is still 3, it's okay. Below and above is abnormal. Always mention the level of conus medullaris in your report. External cephalic version can be done in any case, provided you have space for it. The only space. So it's not like the external cephalic version to convert breech to cephalic. Slight movement, gentle one, so that you get a proper, the plane basically. So if the head is slightly tilted, use your free hand and make it straight. That happens when you have good amount of fluid. So prior to third trimester. So the basic measurements that we discussed in the previous session was BPD, HC, atrial width, transverse cerebellar diameter, and cisterna magna. If cisterna magna appears visually abnormal, then measure it. Now, this is something which is already done in screening, and it does not mean it will not be done in neurosonography. This is all included. So start from the screening and then we'll focus on to the other planes that will be added here. But the basic will remain same. You will add. For fetal echo, if the spine is anterior, you can ask the mother to take a towel. Or you move your probe. If it is bilkul anterior, you are having your probe here. Take your probe to the flank region of mother. Sometimes it comes. But the best is when you have spine posterior and the four chamber view is clearly seen at 11 o'clock position. Your septum is at 11 o'clock position. That is one view which will give you entire axial planes. So that is one maneuver. But again, we cannot do ECV like thing in fetal echo. It is possible in neurosonography. Normal conus L2, L3. So now we'll start the basic discussion. So where the angle changes, you see here, there is upturn of sacrum. You should actually tell me how will you count the vertebra. So this is sacral upturn. So by the second and the early third trimesters, S4 is visible. So the point where this turn is, that junction is between L5 S1. This is how you count in sagittal plane. In coronal plane, you will have the iliac crests. They will tell you the level of L5 S1. So above that, you can count 5, 4, 3. You can also use volume reconstruction, get the coronal of the spine from the rib. You can count 1, 2, 3. Multiple ways, whatever suits you, you can use. So we have a green line, a red, and a blue. So green line is corresponding to which axial plane? Very good. So this is transventricular. Then we have the red line that is passing through this structure. So transthalamic. And when you rotate your probe, you acquire another plane which is targeting my cerebellum. So transcerebellum. So if the head is static and I'm acquiring the images, so transventricular, I go slightly below, you get transthalamic. And when you are taking it oblique, you go to transcerebellar plane. That is simple. But what is the structure which is common in all the three planes, which I usually see to know that I'm in the right plane? One structure where all these three lines are passing. CSP. Excellent. So if you are ever in doubt, you feel that my nuchal fold thickness is coming borderline, it's 5.5, 5.6. Sometimes what happens is baby's neck is flexed. So if you take oblique section, the NF can come thick. So in that scenario, to be sure that you are in the right plane, CSP should be clearly visualized. So if you are in the if you're looking through the CSP, you know that the plane that you've taken is right. And second thing is, you do also do other biometry and repeat it once. But CSP should be seen in all the three axial planes. So what are the general principles? The first thing, whether you are doing the scan transvaginally or transabdominally, only the resolution of image changes, but the foundation is same. You require proper alignment of probe along the correct section planes, and that will need manipulation of fetus as well as your probe. Now your probe cannot be static and you try to just manipulate the baby. No, both will go hand in hand. So whatever fetal position is, if I'm doing a scan, I'm getting good axial section, I'll complete the axial section. If the baby is showing a sagittal section, complete that first. So fetal position will decide which section you are evaluating for the scan first. And don't fight with the baby. Try to accommodate. So if sagittal, do sagittal and wait for some time. Now, along with the axial planes, now we'll be focusing some additional advanced sections, that is coronal planes and sagittal planes. So we have 4 coronal planes and we have 3 sagittal planes. Anatomical assessment is done in all these planes, all the 7 planes, the additional ones and 3 axial planes. Beyond that, when you are evaluating, you will also look for the sulci and gyri. So cortical convolutions are very important and they're going to keep evolve throughout the gestation. So you need to know at what gestation this particular, say, Sylvian fissure, how it looks at 18 week, how it looks at 28 and 36 weeks. So how it is evolving, that is also important. So along with anatomical assessment, we are going to focus on the cortical convolutions as well in each plane. So each plane gives us a focus on a particular convolution. For example, if you're doing transventricular scan, you don't only measure the atrial width, you also look for parieto-occipital sulcus. So these go hand in hand. Now these are our coronal planes. So starting with the first one, something which is going through the frontal lobe, so transfrontal plane. Then going through the anterior aspect of the lateral ventricle, we have 2 structures studied adjacent to the lateral ventricles, that is caudate, so transcaudate plane. Going posteriorly, we're going through transthalamic plane. And then The most posterior plane is through cerebellum, transcerebellar plane. So these are the four coronal planes. So starting with the first. First is the transfrontal plane. Now remember, anterior fontanelle is somewhere here. Posterior fontanelle is somewhere here. Now, if I want to focus on the first three images, I'm going to use the anterior fontanelle plane. Is that clear? If I need to focus on the first three images, I will be using the anterior fontanelle window. With slight manipulation, you'll be able to see three sections. The third section can also be seen if I'm using the sagittal suture as window, right? But the fourth one, the cerebellar plane, will be achieved when you are focusing through the posterior fontanelle. Now, this choice of the anterior fontanelle, sagittal suture, or posterior fontanelle will be decided by the position of baby. So if baby's head is very flexed and you're doing a TVS scan, you will first assess the cerebellar plane, and then you will wait or use the free hand to gently, give us give pressure so that neck extends, and then you can use the sagittal plane or the anterior fontanelle. So that is how you scan. So if you start with the transfrontal plane, it is approached through anterior fontanelle. What are the structures that we see in it? The first one is an uninterrupted interhemispheric fissure. Why uninterrupted? Because we are going anterior to the appearance of lateral ventricle. So it is not being divided by any structure now. So we will have a complete cleaved two cerebral hemisphere with a single interhemispheric fissure. On either side, you will be seeing the frontal lobes. If you are slightly anterior, you can see the orbits, and in the later gestation, you will see olfactory sulci. So in this plane, the focus is on olfactory sulci. This should be present at a particular gestation. If not, then it points to some cortical maturation defect. Okay. Now this plane is lying anterior to corpus callosum, so you will have uninterrupted interhemispheric fissure. Go posteriorly. From here, I'm going slightly posteriorly. Now, slight posteriorly is just angulation of my probe. So tilt the probe or slide your probe to the posterior edge of the anterior fontanelle. So if anterior fontanelle is here, earlier I was focusing through this plane. Now, either I can just angulate the probe or slide it slightly to go to the posterior edge, and I'll come to the transcaudate plane. Now, when you're going to transcaudate plane, you need to see these structures. The first is the frontal horns of lateral ventricle. Now they'll start coming. You will have a trapezoid appearing cavum septum pellucidum. These frontal horns flank a hypoechoic structure which is lying below the interhemispheric fissure. This is the corpus callosum. The falx is seen very clearly, and as the name goes of this plane, transcaudate plane, you will see the caudate nuclei on either side, inferolateral to the frontal horn. These are the basic structures that should be clearly seen. Now again, go to posterior most part. So if you are using the anterior fontanelle, now I need to angulate it even more because I need a further posterior view, which is the transthalamic plane. Second best option, or the option which is more feasible, is slide your probe and go to the sagittal suture. Use the sagittal window. It gives a very good quality image. So sagittal suture is one approach, and the second is anterior fontanelle with lot of angulation. Both will serve the purpose and you will acquire a good transthalamic plane. Now, as the name goes, the first structure that you see is thalami. Okay, you will see thalami. Then the third ventricle in midline. So this thin strip of fluid is in third ventricle. Foramen of Monro is seen connecting the LVs to the third ventricle. And if you go slightly more posterior, for example, this image, then you also see the atrium where you will see choroid plexus. So three planes, transfrontal, transcaudate, and transthalamic. So the first two are clearly seen through the anterior fontanelle. For the third plane, you either angulate it or use sagittal suture. Am I clear till now? How you are acquiring the image? Yes, yes, yes. So what is this? In transfrontal plane, we saw olfactory sulci. So what is this? This is Sylvian fissure. Very good. Okay. Now the Sylvian fissure reminds me of a toasted bread. So this shape should be maintained. Okay. Now beyond the named structure, we also focus on this region where we have basal cistern. Basal cistern contains two things, circle of Willis, and circle of Willis is enclosing one structure which is the optic chiasm. Very important structures we will see in both coronal plane as well as axial plane. So in coronal plane here, in this region, you have MCA arising, ICA, and in middle, optic chiasma is housed. Sylvian fissure, full view you see in transthalamic plane. It appears like a toasted bread. Sylvian fissure is very crucial. Gentle indentation of anterior fontanelle. Slight pressure may be required because it's position where now you have reached the edge. So what do? You apply slight pressure and you improve your imaging. Basically, the end game is to get a very high quality image. Get a good non-grainy, nice definition. Then only you can see this subtle sulci and gyri. So question for you, identify the structure. What is this? First tell me which plane is this. It's little zoomed image, but can you make out which plane is this? Yeah, answer. Axial, coronal, sagittal. Which plane have this images be acquired in? Axial, absolutely right. And how do we know that? We are seeing eyeballs, you're seeing the orbits, and you're seeing the cerebral peduncles. So this is a structure which is lying anterior to the cerebral peduncles. You see MCA also, and you see PCA housing a structure in middle. So this is likely an area of basal cistern, which is containing a circle of Willis, and we have a structure here. This is excellent. So this first the plane was axial, and this is the optic chiasm. Okay, now let us focus. What is optic chiasm? How do we measure it? Now this is a technical thing which we don't do in screening. So something which needs to be focused on. First of all, our goal is to get a correct axial plane. How to acquire that axial plane is, your axial plane should show both the anterior parts of the orbits. So you see the eyeballs in the anterior aspect, and in the posterior aspect, you should see the cerebral peduncle. So you know your axial level is at the level of basal cistern. Optic chiasm is basically an X-shaped echogenic structure, and on either side you have CSF. Okay. Now you are going to place your caliper and measure it sideways. That isn't the normal 2D images. What about color? If I'm not very sure of this structure, I'm going to turn on my color. The color will guide me to the center of optic chiasm, which corresponds to the origin of both the MCA from ICA. So the point where MCA is taking origin at that level, and posteriorly it will be flanked by the PCA. So in between these two, you will see optic chiasm. And the vessels which are connecting them, the PCA and MCA, is the posterior communicating artery. So this is the center of optic chiasm. Now where is the X? The X is this. Can you see it now? That's the chiasm. So it is very nicely seen in axial plane. On the coronal plane, you just see the two buttons. So that's the X. And this is the way you measure it. So using anterior fontanelle, we saw three coronal planes which were anterior. Now we'll go slightly posterior and look for the transcerebellar plane. Transcerebellar plane is very important. It is approached through posterior fontanelle. So this is something for which either you will use your free hand and manipulate, or you will have to wait for the baby to flex the neck if you were doing everything in anterior fontanelle. Now, what do we see in this? The first thing is you see the occipital horns of lateral ventricle, nicely symmetrical. You see at the interhemispheric fissure. Look for another fissure, which is calcarine. Now, depending on the age, if the baby is very small, you're going to see slight indentation only. But if as the gestation advances, you get to see nice echogenic proper sulcus. Okay. Along with that, as the name goes, this is a transcerebellar plane. You will see cerebellar hemisphere and the echogenic vermis. Now, this is the only coronal plane which is accessed through the posterior fontanelle. So, 4 coronal planes done. Now, you tell me these all images. First, which plane are these? And what are we focusing at? Transcerebellar plane, very good. Coronal and transcerebellar plane, excellent. So what are these arrow pointing at? Calcarine sulcus, excellent. So which one is early gestation and which one is the late gestation? A, B, C. Arrange early to late. ABC, CBA, BAC, CAB, whatever. Ascending order, yes. Good. And how do you know it? How do you know this A is the smallest baby, youngest baby? How? Yes, the pattern. Very good. So everybody's paying attention. So first is 21 week. Second is 26 week. And then 31 week. And we are focusing at calcarine sulcus. So this is transcerebellar plane. And we are seeing the progressive development. And that's how every sulcus matures. That's the way how it is. First you have slight indentation. Then it goes inside. And eventually branching happens. So there are grades of maturation. So that is how the maturation happens. And whenever you are screening or whenever you're doing the scan, be it early neurosonography or a later neurosonography, mere presence will not help. You need to see what grade of maturity that sulcus or no, the sulcus that you, whatever you are evaluating is at. Now, some other important but easy biometries are, first is the third ventricle. I have written the definition also, so you know where the third ventricle is. It is the job of this ventricle is to connect the lateral ventricles to the 4 ventricles via foramen of Monro and aqueduct. So in sagittal plane, it looks better. So how do we measure it? First, identify the third ventricle. It lies in between the thalami. So this slit-like structure, anechoic space is the third ventricle, and measure the maximum transverse diameter. Now, at any point of time, it should not be greater than 3.5 mm. So if the width is greater than 3.5 mm, then it should be viewed with concern that there can be an underlying abnormality. So what are the primary fissures and sulci? First and foremost is Sylvian and parieto-occipital. These two should be seen at level 2. Now, when the female comes for well-being, you start focusing on the calcarine sulcus. Now, this is the calcarine sulcus. This is the parieto-occipital sulcus, separating the parietal lobe from the occipital. So, parieto-occipital. Sylvian, from frontoparietal separation from the temporal. And then you have the cingulate sulcus, again 24 weeks. So in these images, you see this is the Sylvian fissure, the POS, parieto-occipital sulcus in transventricular plane. At the level of the occipital horns, you see calcarine sulcus. And in the transfrontal plane, no, not transfrontal, this is transcaudate or transthalamic plane above the corpus callosum. The first indentation is of callosal sulcus, and then you have the cingulate. So this is the image which is telling me at what gestation which sulcus should be present. At 18 weeks, Sylvian fissure, 20 weeks, parieto-occipital. So level 2, we should see both. Then comes the calcarine fissure at 24 weeks, cingulate at 26. By 28, you should start seeing central sulcus, the temporal sulcus, olfactory sulcus. So in transfrontal plane, you will look for olfactory sulcus as well. And then by 30th, almost everything matures. So this is the cycle. Now, how Sylvian fissure matures? At 16 to 18 weeks, there is just a slight indentation. It appears like a slight, small, shallow groove. Level 2, it becomes a smooth, angled groove. Later on, the angle is increasing now. It becomes 45 degree, this angle. Then 90, by 24 weeks, this is 90. Now the temporal and the frontal operculum, they start overgrowing this space. So this is my frontal operculum and this is temporal. They start overgrowing and coming close to each other. Now when they're coming close to each other, they are basically narrowing the space, the depth. So they'll start growing. 26 to 28 week posterior half is 1/4 ridden. So if I divide this into 4 spaces, you see only 1/4 is ridden. Then it becomes half. By 32 week, posterior half is ridden. Then 36 week, it completely opposes. So now you have a sort of branching. So that is the how the Sylvian fissure evolves. And what about the measurement? Should we measure Sylvian fissure? If in doubt, yes, definitely. There is a quantitative method to it. So how do you measure it? So axial transthalamic plane is taken and measure it from the, see, this is the lateral edge of the roof of the fissure till the inner part of the calvaria at the widest part. So this is how you measure the depth. It should be parallel to the BPD plane. And then you have nomograms. So Sylvian fissure, if you find it, it is shallow for that gestation, then it can indicate a cortical malformation, like listen carefully. And it can be associated also with multiple cortical malformation. In addition to this quantitative depth measurement, morphology also needs to be evaluated in both the axial and the coronal plane. So this is the morphology that we saw. So for that gestation, how is the morphology progressing? So look for the morphology and also the depth. If you feel that this does not look well. Along with that, if one fissure is giving me some doubt, I'll also look for the depth of other fissures like calcarine and the parieto-occipital fissure. Then coming to the sagittal views, we have 3 sagittal views. One is mid-sagittal and then the 2 parasagittal planes. Right? Now, mid-sagittal plane also has 2 things to evaluate. First, we have an anterior complex and then we have the infratentorial posterior fossa region. Now, if I want to evaluate anterior complex, what does your common sense say? Which area should I approach? Which fontanelle should I approach? Anterior, posterior, or sagittal suture? How should I look at this region? The anterior complex. Very good. So anterior fontanel or sagittal suture. Now this is through sagittal suture. See, they have applied slight pressure. When you focus, there is indentation of the bone. So anterior fontanel or sagittal. Anterior fontanel will give you very good images. Sagittal will give you a broad picture, again with a very good imaging, and posterior fossa is also somewhat seen. But for posterior fossa, we'll focus through posterior fontanel. Then you get very good quality images. So mid-sagittal plane, the median plane is the reference plane where you want to study the entire midline structures there and their anomalies. For a complete supratentorial and infratentorial anatomy, we have three windows: anterior fontanel, posterior fontanel, and the non-ossified sagittal suture. So whatever area interests you, if I want to focus in this region, I shall be using anterior fontanel and focus in the anterior complex. If I want to see the posterior region, I will focus through posterior fontanel and focus on the posterior fossa. So you have three windows, you can use either of them. The aim is to get a proper insonation, and that can be achieved by gentle manipulation of fetal head using the free hand.